Hi, Despina. Thank you very much for this privileged invitation. The organized committee and Mr. Dimitropoulos, I'm very delighted to be a chairman in this innovation course. And I would like to introduce you our special guest, distinguished guest, Mr. Nasos Zouzos. He's a chief of breast imaging department at Karolinska University Hospital, and he will speak about vacuum-assisted breast lesions excision. And as commentators, Mr. Venizelos and Ms. Stathoulopoulos, great breast surgeon at Metropolitan Hospital in Athens, and Mr.
Tassis.
Who is a chief radiologist in the department of Euroclinic Hospital at Athens. Mr. Zouzos, we eagerly waiting to hear your presentation.
We don't have good sound.
Yeah, I lost it at the end, but thank you for inviting me. I will try to share my screen now. Just give me a moment. So hello from me also. All the presentations were really interesting today. Really organized conference, I would say, or webinar. Thank you for inviting me and for giving me this opportunity to speak about VIA and what we are doing here at Karolinska University Hospital. To begin with, I have to present the disclosure, and I may have received the grant from BD, and I thank them for that, but the reason I'm doing this is because I believe in this technique, and I really hope we can contribute in the fight against breast cancer and cancer in general. Here are the disclaimers, which I'm also obligated to show to you. And I quickly will go through the overview of VIA technique, especially for you that are not familiar with it. I like the definition that is written in UK guidelines, where VAB, in other words, vacuum-assisted biopsy, is meant to replace the conventional 14G core biopsy to make a diagnosis. VIA, on the other hand, is where vacuum is used to replace the surgical diagnostic biopsy. The needle and the technique in general is the same, but the aim is different. The aim of VIA is to take plentiful tissue, about 4 grams, and as a result of that will be to totally excise the lesion if the size is smaller than 15 millimeters, or likely to obtain representative sampling of the area if the lesion is more than 15 millimeters. Already in 1998, we have the first published paper where the research group Zanis et al. Compared open surgical biopsy with stereotactical vacuum biopsy and published the results at the American Journal of Surgery. The key points of this study were that VAB procedures were less invasive and less morbid than open surgical biopsies, and that no underestimation of disease was seen with VAB. They concluded that the breast surgeon can use VAB to replace open biopsy and core needle procedures for the initial biopsy of null-palpable breast lesions. Since then, the devices have improved, and we are now in the condition to perform VABs even with the help not only of stereotaxy, but even with ultrasound and MRI. So the main idea for almost all devices that are in the market right now is to cut and take out the tissue into a separate basket without taking out the needle, with the help of vacuum, and repeat the procedure until the whole lesion is being removed. VAB is already, I believe, in our everyday practice, so the next question is how to do via our everyday practice. For that matter, we needed in our department a guide of actual personal experience to this already widely approved method. Our surgeons wanted also to be sure that we know what we are doing so they can move the burden from their shoulders to ours. That is why we decided to design a study so to be on the safe side. So about that we have the informed consent of every patient. We monitor and document everything we do, and at the same time, we try to answer a lot of practical questions. For example, if we have the choice between 10 and 7 gauge, which one should we use? What is that the patients are experiencing during those procedures? As far as we know, there is no actual study published referring that question in such big size needles. How can we confirm radicality? Radiology is unfortunately not always the best way. Even we don't see the lesion, it doesn't mean that the lesion is out. To answer those questions, we decided we needed at least 200 patients. For the first question, we planned a prospective randomized study where we randomized between 10 gauge and 7 gauge needle size and tried to calculate the procedure time and the complications for each group. Then for the second question, we used a reformed and already validated questionnaire that will be collected 2 or 3 weeks after VIA and again after 6 and 18th months. In this questionnaire are included 10 questions, as for example, the amount of pain that the patient had during the procedure or how she feels about the cosmetic result. For the third question regarding radicality, we have 3 different steps. Visual confirmation, pathology report in 3 separate baskets, and follow-up for more than 2 years. So at this point, I would like to present some preliminary results. For the first study, we have until now 150 patients included, divided into 2 groups. The procedure time presents here the actual doctor's time. That means the time when the doctor is coming into the examination room to perform the procedure until the time he or she is leaving the patient's room. As you see, the difference is almost insignificant, and the mean is calculated to 38 seconds. As regards the complications, within 8 weeks from the time of the procedure, 85% of the patients had no complications at all. 4% experienced excessive bleeding besides the 10 minutes compression we always perform, and those were independently from the size of the needle. 5% experienced hematomas in the form of a lump that stayed for some weeks. We had one incident of skin laceration where we had to call the surgeon to make a beautiful stitching, and we also had one case of infection where the patient went to GP to prescribe antibiotics. 4% of the patients experienced a lot of pain afterwards, mainly radiating along the arm to the point they could not do their everyday activities for some days. As for the second study and the questionnaire, I will present here 3 of the 10 most representative questions, such as the pain during the procedure. We asked the patient to validate the pain they felt from 1 to 10, the scale of 1 to 10. As you see, 90% of the patients recorded pain levels up to 5, which is supposed to be acceptable, and 10% of the patients recorded pain levels above 6. Now about the cosmetics, we asked them if they were dissatisfied with the result. 83% of the patients answered not at all. Final, about if they would recommend the procedure to another patient, the answer was yes, for up to 98%. The third study was the most difficult one, and regarding the radicality evaluation. We first use, as previously said, visual confirmation, where we encounter some problems, like, for example, bleeding during the procedure, which obscure the visualization of the remains of the lesion. Still, we evaluated that the procedure was radical on 80% of the cases, 20% no or unsure. And from those 20%, we managed to get another 20% confirmation from the pathology report that the lesion was probably radical. This gives me the pass to speak about the second try to evaluate radicality regarding the amount of fractions we took out from the breast. As I previously mentioned, our goal was to perform the excision in 3 steps. The first step includes to put everything we take out from the breast to a basket up to the point we don't see the lesion. So the whole lesion or the small bites of it will be in the first basket. Then we continue to excise for 2 or more circles and put the tissue into 2 different baskets. When the pathologist examined the material, we asked them to give us 3 separate answers. Only the first or at least the second basket should contain parts of the lesion. The third should be free. We soon though realized that we couldn't always take out 3 fractions for different reasons. If, for example, the lesion was too close to the skin, or if the patient didn't want to continue, or because of the bleeding that we encountered. So the results were that we managed to take 3 fractions in 37% of the excisions, 2 fractions in 41%, and only 1 fraction in 22%. This result had nothing to do with the size of the needle. As you understand, the radicality with this method can be assessed only if we had 2 or more fractions, and the results for complete excision was 65% for 3 fractions and 30% for 2 fractions. That means that we really need to struggle and continue excise the area as much as possible. Besides those previous evaluating methods, we have, of course, even the follow-up 6 months now, where radicality was confirmed in 80% of the cases, including microcalcifications, and 91% excluding those. Those results are a little worse, but although in line with published literature where the reported mean is around 95% for benign lesions. Well, nowadays we perform almost 5 excisions every week, and we have now a line of 60 patients waiting for their intervention. The lesions that we include in our everyday practice are microcalcifications up to 10 millimeters without previous biopsy, not pre-series, there's a typo there. Repeated, palpable benign lesions if the patient wants it removed. And the size here can be up to 3 centimeters. Repeated blood secretion without ultrasound findings. Papillary lesions with or without atypia on core biopsy, up to 2 centimeters, and we have also ADH or IDEP, as the Englishman preferred, and FEA and lobular neoplasia, also up to 2 centimeters after core biopsy. Phyllodes and radial scars are excluded from our study and VIA in general for different reasons. Phyllodes, the pathologist would prefer to have the lesion as a whole to make a safe diagnosis. And for the radial scars, it feels actually a little bit insecure to manage to extract all the radiations from the lesion. And we know from the literature that small in situ carcinoma can be in the radiations, not in the center of the lesions. So besides those mostly benign lesions, we are building experience even on small cancers under 50 millimeters, where surgery is not possible, and even on lymph nodes on palliative patients in the axilla. This gives me pause to speak shortly about our nearest future, namely the mini-VIA study. We are building a collaboration with Professor Ritchie Mann from Holland, who is also responsible for this protocol. And in this study, we are going to contribute with 30 cancer patients and share our results. This is a multi-center translational clinic phase 2 study in 170 women with cancers under 15 millimeters based upon ultrasound and MRI measurements without mammographic or MRI evidence of more extensive disease. We are going to perform VIA, and then subsequently will the surgeons perform the operation of the remaining cavity and control if any remaining cancer cells were on site. And again, I'm going back to the first study in this matter that was published in 1999, where the authors used an 11-gauge needle to try to excise malignant lesions stereotactically. Key points here were there was no residual carcinoma, the surgical excision in 17% of the patients, and that the largest lesion completely removed in this study was 7 millimeters. The mean was 4 millimeters, if I remember correct. Their conclusion was that removal of non-palpable mammographic malignant lesions measuring less than 1 centimeter is possible. although not so many efforts have been done on malignant lesions since then, we think that now with the evolution of this technique and the possibility to use ultrasound guidance, the time is right to proceed with such a trial. Last but not least, I would like to speak about our second phase in our study on women who saw complete response after neoadjuvant therapy. I had some also notes from Dr. Varaki and Dr. Lanitis about that. I would like to mention that our surgeons are planning and rearranging their operation techniques depending on neoadjuvant response for almost all cancers that are greater than 10 millimeters. For example, a 7-centimeter tumor undergoing neoadjuvant therapy which reduces its size to 3 centimeters will undergo excision of this 3 centimeter size area and leave the rest. But what about the cancers that show complete response? Why to operate a 10 millimeter carcinoma that has complete response to therapy? The problem lies on our limited diagnostic accuracy, of course. Due to this diagnostic uncertainty, surgery after neoadjuvant therapy is considered to be obligatory for all patients in order to either completely remove residual disease or to diagnose pathological complete response. The purpose of this trial is to evaluate accuracy of a vacuum-assisted biopsy to diagnose complete response after neoadjuvant therapy prior to surgery. The protocol is being developed right now, and for those women who decide to participate in the study, we will perform VAP considering what was learned during the first studies 1 to 3 that I mentioned before. We will excise a number of millimeters of the original tumor site for women who show complete response on MRI and eventually on PET MRI. As we are lucky to have one of the few PET MRI machines in Sweden, we are going to use it to confirm eventually remaining viable tumor. All study participants will subsequently undergo surgery as in routine practice, and we will evaluate if the PID of the PAD results agree with VAPs and surgery. I'm going to show you 2 already ongoing trials regarding this matter, and I will close with that. The Responder, a multi-center diagnostic trial from the University of Heidelberg, where the group will perform VAB to every tumor independently of characteristics. And of course, the synagonistic trial from MD Anderson. And the difference with the Responder is that the group here is only including patients with triple-negative breast cancer and HER2-positive breast cancer, which are, of course, the groups with the highest probability for complete response after neoadjuvant therapy. The difference from those two from our study is the use of PET MRI, who will be used in combination with our VAB to diagnose the complete response prior to surgery. Thank you for listening.
Thank you, Mr. Katsaros, for your excellent presentation. I would like to call Mr. Venizelos for a comment, please.
Good afternoon, and thank you very much for the invitation. Well, a very nice talk for the future, Dr. Zavos. I still believe this is a very nice method, but I'm really interested to speak for the time being and not for the future. I mean, these are very, very nice cases for the future, for the days to come, for the years to come. And I'm really worried about, I'm a breast surgeon. I'm a president of the Hellenic Society of Breast Surgeons. And I have to think about removal of the tumor by using this method. What is the point? What's the point to perform this type of procedure? Because in any case, patients, they will go to theaters for the removal of the sentinel node biopsy. Unless you are doing both procedures using this device, there is no need to do one device and after that to take patient to theater. Also, I still believe, because I'm doing this method, I still believe this method is for the benign lesions. And as far as I remember, years ago at San Antonio, there was a presentation about the use of this device after the neoadjuvant chemotherapy, and the results were not very promising. Therefore, okay, this is a very nice work. I'm not sure that it's going to give some very good results at the end of this procedure. Secondly, what is the need to use 7 versus 10 gauge needle? You can remove the lesion, if the lesion is benign, by using a smaller needle. And third question, do you perform any fine needle aspiration before the procedure? Do you do any core biopsy to know if this lump is benign or is a, let's say, tumor? These are questions. I mean, we have to answer that, okay? This is a very nice procedure. Yes, I will agree. I mean, everybody agrees with that. It's a very nice procedure to remove benign lesions, except the phylloides tumor. I totally agree. But what about the fibroadenomas with DCIS inside it? And also, everybody knows that we need confirmation if the lesion is benign or not. We have benign lesions. I mean, we have cancers, they do like benign lesions. We need the pre-procedure confirmation with some type of biopsy, either core biopsy or fine needle aspiration, which I don't like it. But I prefer core needle biopsy. For microcalcifications, I totally agree. This is being a surgeon, this is my advice for my patients. I'm not taking them to theater. I would like to do, first of all, vacuum-assisted biopsy to confirm the diagnosis, and after that, 15% of those patients will take them to theater. I will agree for the limit of 1 centimeter, that means can be removed by using this method, but I'm really worried about the free margins. And we have to take in discussion that free margins is a dependent factor for the local recurrence. Very nice work, congratulations, but I have some worries about it. Thank you very much.
Mr. Tholopoulou.
Hello, everybody. Dr. Dimitropoulos, thank you for the honorable invitation. Very nice presentation from all the inviters here from the morning when I am watching all this very interesting conference. My director, Dr. Venizelos, covered me with all the, yes, he said everything I would like to say about that this method is not, we are not having still the data to proceed in this method as an excision, at least for the malignant lesions. We use it only diagnostic. That's the point. We cannot say, and we are not having still the information and the data to proceed and make this method as to omit surgery instead of this method. And I would like to ask you something more. You said that we remove the microcalcifications BRIC with VAE under ultrasound, you meant?
No, stereotactically.
Stereotactically, okay.
Yes.
Okay, that's my point. We are surgeons, breast surgeons. We must not be, we are hopeful, all we feel hopeful about these methods and we use them. Of course, we're using them very much in removing complex fibroadenomas, which until 5 years ago, 3 years ago, it wasn't a guideline for us, but now we must remove them when in the core biopsy we have complex fibroadenoma, and this method, VAE, is very, very useful to them.
Yeah, yeah. If I would like to comment, if it's possible.
Yes, of course.
Thank you. Yeah, for the first of all, yeah, of course, removing malignant lesions is something totally new. I mean, the trial we're doing now with Dr. Ritchman from Holland is a trial. There's a lot of research now, and everything goes to minimum therapy. I'm not sure that I really believe that in the near future, even with if you have a 10 millimeters invasive carcinoma, you will not have to do a sentinel node operation. So let's see how the future will show, what the future has to show. Then we always perform biopsies, core biopsies, before we do the vacuum. So we have a core biopsy, we know what the lesion is, and then we go to the vacuum. And we have said, although we have done a core biopsy, that we had some upgrades. For example, a benign papilloma on core biopsy is invasive carcinoma in the vacuum. Then the margins, we will see how big the role will play in the future. But of course, this method I present now is for BRIC 3 lesions, not for malignant lesions. It's only for in the trial we are doing that.
Okay, what's your opinion, Petros? Could you please say something? Because you are an expert in VAB.
I'm not exactly the expert. Of course, VAB is the future. Okay, all the benign lesions, B3, it will be the gold standard to remove by VAB. It is less in cost, less in time, no anesthesia, it's safe if the radiologist or the surgeon it's capable to use the ultrasound and have the experience to do it. Personally, I know just Vasilis Venizelos that as a surgeon that do that. My experience is minimal. It's not so big. About 30 cases of removed lesions after a core biopsy that they proved that they were benign, mostly fibroadenomas and 2 of them papillomas. The size was between 1 to 2.3 centimeters, and I didn't have complications severe. So mostly hematomas. I used Sonorix, and in 2 cases elevation. It's without all this device. Of course, all the VAB systems they are capable to be used. The size of the needle was 10G in smaller lesions and 7G in the bigger. I think if the cost of the needle be logic, is the best way to remove benign lesions. And we need training, a lot of training. This is my comments.
Okay, thank you very much. I pass the microphone to Ms. Christodoulidou. Thank you.
Can I say something? Okay.
Yes, yes, please.
Vasily,
Okay. Well, I still believe. I still believe that this vacuum-assisted excision is going to play an important role in the future. Okay, I will accept that. And there are quite a few questions now. BRIC 3 microcalcifications. Why should we remove them? There is no any need for that.
Because if there is an ADH on
Excuse me? BRIC 3 microcalcifications, and I'm asking the other radiologist, is it necessary to remove them? That means you're telling me that I'm going tomorrow in my practice from Monday morning, and when my radiologist says that this is going to be a BRIC 3 microcalcifications, I will advise the patients to have them removed. This is your advice? Because I will totally not agree with that. Secondly, I will not agree with your point about margins. Margins are very important in the breast cancer patients, very important. And there's a lot of talks, speeches, papers, hundreds of papers discussing about margins in the DCIS era. Therefore, we have to be very, very careful about when we're going to remove a lesion, we need margins. And the main issue is to recognize margins. When you are going to remove a lesion of 1 centimeter DCIS grade 3, ERPR negative, HER2 3 positive, you need margins. Therefore, you have to establish the method when you are going to see the margins after doing this procedure are clear, and these are the margins. And you need a follow-up, not only 1 year, you need a follow-up more than 5 years to be safe to say that this method is going to be done, and we'll advise the patient to have this method in a small 1 centimeter DCIS lesion. Therefore, there are a lot of questions about these methods. I mean, I totally agree that we need less invasive methods. Yes, I totally agree. And we have to be safe though, okay? Very nice to promote the vacuum-assisted excision, but I think we have to promote that in a benign lesion, and we need a lot of trials to have a conclusion that this method can be implemented as well in the malignant lesions. But anyway, thank you very much for the talk, and I'm waiting for your results. Thank you.
Thank you. Thank you.
Julia, it's your turn now.
Yes, I know. I would like to say just one tiny word to Dr. Venizelos regarding all his thoughts and very sincere and honest doubts about the vacuum-assisted excision, cryoablation. And now we proceed to the last but not least speaker of the day, who is Professor Marco Moschetta, an assistant professor of the Department of Emergency and Organ Transplantation all'Università di Bari Aldo Moro. He's a staff member for the last 13 years and an expert in breast interventional procedure. His lecture is titled New Technologies and Workflow Impacting Vacuum-Assisted Biopsy. Please be aware of the timing due to the long of the day. Commenters will be Dr. Venizelos and Dr. Stapilopoulou, and also my dear friend, Dr. Malakassis, who is a breast interventional radiologist. Professore, la parola a lei. Grazie.
Thank you. Good afternoon. I would like to thank you for your introduction, and also let me thank also the president, Dr. Dimitropoulos, for the kind invitation. I'm going to share the screen, and we start with the Okay, with the presentation. I will be in time, so I hope we will not have a delay. And about the new technologies, we will concentrate with the new technologies applied to DBT, so three-dimensional vacuum-assisted breast biopsies, because today we have new devices. Okay. Oh, sorry for the video. So the new possibilities we have for using this kind of VAB applied to the stereotactic view. We know that VAB, we'll just listen about the possibility also to treat lesions and for the excision, but we know from the literature that VAB has proven clinical value and can be used under sonographic, so under ultrasound or mammographic or MRI guidance. But classically, this kind of procedure started for microcalcification or for lesions that were only visible on mammography or digital breast tomosynthesis. Of course, just a few minutes for a background, we follow the BRIC's classification of lesions, and all of us know this kind of classification, and especially for BRIC's 4A, B, and C, so especially for the 4C category, and which are the main indications? We know that the main indications are represented by masses or calcifications, architectural distortion or asymmetries, and just a few minutes for this. And the indications are represented from BRIC 3 or 4, or for example, for very small lesions under 5 millimeters, where we can have problem, or for example, CNB, or not diagnostic CNB at the first level biopsy, or BRIC 5 and 6 before neoadjuvant chemotherapy. So, for this kind of procedures, till now we use for the stereotactic way, the two-dimensional, or for example, some upright position if we will not have a 2D table, or with the upright or decubitus. And these are the needles that we already listened before. Of course, if we use a higher diameter for needle, for example, 8 gauge or 9 to 11 gauge, we have a more quantity of tissue. And this is important, but for pathologists to have a short diagnosis, but literature said that this kind of quantity does not directly is not directly related for the final diagnostic examination. And this was the past with this kind of tissues born for microcalcification, and also these are the examples of control. For DBT-guided vacuum assist breast biopsy, we, from the scientific literature, know that the clinical performance was superior to the standard prone stereotactic VAB, and this is because we can have a full detector size for imaging, we can have immediate lesion depth information and identification, we can avoid the triangulation as in the past with the -15 and +15 and 0 for the triangulation of lesions as in 2D, and then we have an identification if we need to reperform a target lesion, etc. And then as a complex, we have more than 47% that we can identify with digital breast tomosynthesis. So of course, this is the guide. This is because in the clinical use, for sure not in the organized screening, but the clinical breast imaging, we use today tomosynthesis, and we know that in this way we avoid the tissue overlap, we have a better anatomic visualization, we have less dependence on the technical skill of radiographers, and also we can reduce multiple projection as in the past. I'm going fast in this part because we already know this background, but for sure we can find 41% more lesions, and this is what we have from some studies in the past with increased detection of invasive cancer, but we need to remember that we can identify more B3 lesions, so maybe not all architectural distortion could be malignant, or for example also for some microcalcification they could be for example 4B or 4A. They are simple. These are some examples of architectural distortion. For calcification is important because we change the classification, and so today we perform only in case of suspicious morphology, and all of us know the suspicious morphology for 4B or 4C, and also we need to follow the distribution, group, regional, diffuse, segmental, etc., always following the Barrett's classification. If we want to perform this kind of biopsy, we usually, in a few minutes, we will see the advantages. We start in 3D imaging if we can see exactly the target. But today we have the possibility, without decompressing the patient, to change from 3D to the 2D procedure. For example, if we can't identify the cluster in 3D imaging. This is because some malignant calcification may be suppressed at DBT also at the time of the procedure. We can have, for example, lowering plane resolution or artifacts that can jeopardize the depiction of microcalcification. This is the literature, but if we are in the daily clinical practice, we can move from 3D to 2D biopsy. So as in the past with the triangulation of lesion, if we can't identify the microcalcification, or if we are in the case of a small cluster. So the conventional stereotactic biopsy for calcification could be still needed in these cases for small clusters. And then some studies evaluated the performance of DBT also in these cases and compared with the possibility of having these biopsies with 2D imaging. And of course, for the 4B and 4C microcalcification, as we can see from literature, we have a superior for the possibility of having a higher view, or for example, a higher view in for the detector that we can use with these new devices. So stereotactic could be, of course, safe and cost effective to diagnose malignancies in case of suspicious microcalcification. The second category was, as a background, the architectural distortion. All of us know that we follow the main rule of white star for cancer and black star for sclerosing lesions. So of course, we can have enhanced imaging, for example, contrast enhanced mammography or MRI, in order to have a differential diagnosis. But of course, we prefer biopsy in all cases in order to have an histological, of course, diagnosis. And so beyond the imaging, we need to perform this kind of procedures. This is also what the literature today says about the presence of this kind of target, and this is the malignant rate of DBT-VAB for architectural distortion, especially without sonographic or with sonographic correlation, and high-risk lesions, 33% of biopsy. And we know that when we don't have an ultrasound correlate, so we perform the stereotactic or 3D biopsy, we have more radial scars and sclerosing lesions as compared with other lesions. They have a correlate with other imaging modalities. The last category is asymmetries, and we know that we have a spectrum of asymmetries, so global asymmetry, focal asymmetry, or developing asymmetry. Of course, for us, focal and especially developing asymmetry represent the main indication for this kind of three-dimensional stereotactic biopsy. And in fact, we know that focal asymmetry is not when it's not present to prior mammography or, for example, prior DBT examination, of course, still requires the stereotactic or 3D biopsy. This is because invasive lobular cancer can appear in this way in a lot of cases. So we need to integrate imaging and then to perform the biopsy. Today, after this small background, we need to understand which kind of new technology we can use. I'm talking about the possibility of having a three-dimensional prone biopsy by using a table that is able to perform the 3D biopsy. We know that we can have some challenging from patient positioning, and so, for example, the upright position could have some problems. So imaging, because also the possibility to have a good target with a full detector, the targeting, and also the breast thickness, because today this kind of devices have a small thickness also in order to perform, also in case of small breast, in the prone position, the possibility to having this kind of biopsy. So I'm talking about the small or thin breast, the superficial lesion also very close to the skin, or the deep lesion on the opposite that are exactly on the opposite position, and so very adjacent to the chest. Also, in this case, we have some studies that compare the upright position, for example, with the prone stereotactic position with the previous systems. And there is a bit of discordance in terms of, for example, time, in terms of targeting, in terms of histological samples, and also comparing the stereotactic biopsy with the 3D stereotactic biopsy. And of course, we need this kind of devices because today we work with digital breast tomosynthesis. So of course, we have higher performance with these systems. New technologies, because we use prone biopsy system, we can have faster procedures that today have a mean duration of 6 to 7 minutes. They are, of course, more comfortable by increasing the automation, because we can have a 360 approach to the breast gland. And this is very important, as I told before, for those kind of targeting that could be very challenging in case of the previous systems, and also a superior imaging. We also noticed that this kind of procedures could be comfortable. We have increasing automation, superior imaging, and it is important that we, as I told before, for microcalcification, so for the first group of lesion, that we can change in any moment from 3D to 2D imaging if we need to return to triangulate lesion or microcalcification. And so we have less time of compression and easy detection with the high field of view, and at any time this kind of changing. The real new approach is that today we can have a bidirectional patient positioning. So while in the past, when we use these prone tables, we have the breast hole in one extremity. Today we have this kind of stereotactic approach in the center. And so this is good because we can have a bidirectional positioning. So for example, if I have a lesion in the lower quadrants, I'm not obliged to perform the lateral approach as in the past, but I can go in the transverse compression, axial compression, and in the caudocranial approach. This is a very new possibility that we have, especially in those cases when we see, for example, a distortion in only one projection. That could be, for example, the transverse projection or the axial projection. We have a C-arm rotating for 180 degrees, so we can change the approach. We can have a lateral needle approach. And the other important innovation for the fast procedures is that today we can have, in case of microcalcification, an integrated sample imaging. So we can immediately have the sample imaging without transporting this kind of our samples to other mammographic unit or other small radiological unit dedicated only to this kind of breast samples. So this is the examples of the C-arm and bidirectional patient positioning with 360 approach and the possibility of switching. After the table, the workflow is new because today we also compared from conventional stereotactic procedures to 3D DBT guided procedures with this kind of devices, that from the classical 8 steps, we moved to only 3 steps for performing the procedure, because in the past we had to start biopsy, then to take samples, to remove samples with the manipulation, to prepare samples for imaging, to transport for another imaging unit, and then also to manually prepare samples, to place our maker, and to prepare samples for pathology. Today, this kind of new technology is able to reduce this workflow only into 3 steps represented by the biopsy, and then all these steps are joined into only one, because we have the integrated radiological imaging of the sample. So we can take samples, we can image the sample at the same moment, and then we can verify and prepare sample for pathologists directly without any manipulation. And the only last step is to place the maker and verify the presence of the maker. So the advantages are represented by real-time imaging without time consuming, the immediate verification of the samples, the image manipulation to identify also some fine microcalcification that could be difficult to identify in other system, and then high resolution display of core images and system navigation. So this advantage transferred into a clinical context, the fast procedures, we can improve the workflow efficiency, we can use the other units for screenings or other biopsy procedures, we can verify instantly at the same moment the samples, and of course, we can have less duration of breast compression and so a better patient satisfaction and experience. Just for educational, some cases of our, after the use in the last 3 years of this kind of devices, here we have a cluster of microcalcification of the left breast in external, and this is also on DBT we can identify, so superior and external also on DBT. So it is very simple to perform the target. We have a complete view also on the not compressed remaining part of the breast, so it is very easy to localize, and then we can directly perform the biopsy. We suggest after the anesthetic always a control in these cases, because we can have a movement of the microcalcification after the anesthetic, and this is the immediate imaging that we have for each sample. So for example, if I also already have a microcalcification in the first or the second sample, I can also decide to stop the procedure without performing all the 12 samples that usually we can identify. And then we place the marker. This is important, especially in this case, because we have a complete excision of the lesion. This was a second case with a double lesion. This is the median quadrant, it's superior, always of the left breast. In the tomosynthesis identification, we have focal asymmetry with microcalcification. So this was the first procedure with the possibility of sampling microcalcification, the direct visualization of microcalcification. So it was a successful procedure again. And this was the end of the first target. We placed the maker and we moved without compressing again the patient to the second. This was the second cluster of microcalcification already verified, and the final procedure. Then we had 2 focal of B5. This was with the hook wire identification, but we can also perform with roll or other procedure that in our center we can use. And it was very easy and simple. This is a case always of microcalcification, but very difficult with the previous table, because we had more thickness of the table, but today is very thin also. And this was very deep in the inner quadrant of the right breast, inner quadrant, just on the pectoralis. This was the lateral view in the superior quadrant, the digital breast tomosynthesis view. And again, we had the possibility of performing in the lateral compression with the lateral approach of the needle, the targeting of the lesion, and again, the immediate verification of the sample. So this was the first, this was the second, and just in the first and the second, we had the possibility of having the integrated imaging. So these were 1 and 2, and then we also performed the others. And this was the final part with the maker positioning inside this kind of deep lesion. So of course, this targeting could be very difficult with the previous technologies. This was another case, always of microcalcification. It was a low grade, the histological report at the end of procedure was a low grade DCIS. And so here is the targeting. We can decide to perform both in 3D or 2D imaging. And again, the possibility of having a direct verification of the sample. If we move, this was the CIS when we decided to, of course, have the excision. These are some cases for the DBT and 3D imaging, because in these cases we are obliged, we can see the lesion only on the DBT scan. So we have, again, on the left side, superior and external quadrant. Maybe it is a black star, so we have a high probability of having sclerosing adenosis. This is the targeting with all the very high field detector, and we are inside the lesion. We perform, because it is automatic, so we have a lot of automation. Also in this case, we perform the automatic integrated imaging, X-rays imaging of the samples. We also have some microcalcification in this case. This was another case of architectural distortion in the superior inner quadrant of the left breast. Again, maybe this is a white star. And so we have one-click target, so immediately, without the need for triangulation, we are inside the lesion as control, and the procedure was in 4 minutes already finished, and it was an invasive and non-special type cancer, invasive ductal carcinoma. The last case, again, for the 3D, we have architectural distortion, again, on the left side. It is very easy for the targeting with one step without the need for triangulation, and this was the final part with the marker. And again, it was an invasive lobular carcinoma that went to surgical excision. Just a few seconds, because today we can also join this new technology that is completely automatic with artificial intelligence. We know that when we perform this biopsy, the operator has this challenging, again, for positioning, imaging, targeting, and this will depend from the choice of the operator, of the radiologist. So today we can join this kind of view with artificial intelligence, because if we decide for having a lateral approach, or for example, lateral compression or axial compression, if we use neural networks that are today developing in the field of artificial intelligence, we can start from the DICOM imaging and the CAD detection. And we have tried also with our physicians and with our engineers to perform some radiomic studies on the breast. And so probably after windowing, after the quantitative transformation of our data from this automatic device, we could have some results with a 3D view of the breast, and probably the system will suggest to us which one will be the most safe approach to the breast. So for example, on the cranial compression or lateral compression, or for example, on the lateral approach of the needle, depending on the distance of the lesion from the, for example, the pectoralis, or from the skin, or from the slices. So the number of slices, that means the thickness, the global thickness of the breast gland that we are going to biopsy. So I think that probably also the next future will be this kind of new technologies, very fast and automatic, joined with the neural networks that we could have from artificial intelligence. This is our group of breast imaging that we have in our department. And I don't know if it is too late, but we also have a small videos of 2 minutes if you want to show the procedure. But if you think that it is too late, for me is enough also the presentation. I don't know.
I think you should proceed to your video.
Okay. Because when I talk with the, we could have some education, and this was one of the last procedures we had. And so we had the patient directly on the prone position. We decided to perform a caudocranial approach, okay? And so here we have the targeting that is, in this case, microcalcification. We don't need triangulation of lesion, okay? And so we are going to perform the anesthetic. This is the C-arm rotating for 180 degrees, okay? And this is the procedure that we are going to perform. As I told before, it is useful to have imaging control only in this step. That means when we have very small cluster, they can move after the anesthetic. And so it is very comfortable for the patient because the patient can't see anything, okay? And so after the anesthetic injection, we are going to control if the target moves. And in this case, we decided to perform triangulation. And so we had the passage from 3D to 2D imaging. After the anesthetic, we are going to perform the second. And we notice that the cluster remains in the same position. So the target could be the same. We don't need to cut the skin because it's a very, the morphology of the needle is very simple. So we are just going inside the target. And now we will start biopsy. Here we have the fire of the needle. Usually the protocol includes the imaging control for post-fire imaging, but we can also proceed if we are sure that we are inside. These are the 3D spatial view. So we start when they are green. And this is the immediate imaging of the samples. Okay, so we start with the biopsy. And it's very fast because we don't need to have any manipulation of samples. And we are starting with the VAB stereotactic. And we are waiting for, this was the first part, the first sample. Of course, we have separate chambers for the samples. They are very useful for our pathologists. And this was still the third one with some very small or faint microcalcification. But okay, and then we are moving to continue 12. Okay, and now they were located at number 6, so in the lower part of our chamber. And this is very useful because you can have, without any manipulation, the imaging of the samples. So we are still continuing the procedure. The main duration was about 6 minutes. And this is the sample. Okay. So at this time, we don't need to remove samples. They can directly go to our pathologist. We can just take the samples and we are going to remove with our nurses. So they go directly to the pathologist, and then we can have the aspiration and the marker that we need to position inside. It was just an example for these new technologies that we suggest in case of breast biopsy. Thank you for your attention.
Grazie, professore, grazie. It's true that the technology helps us a lot with the preoperative diagnosis as radiologists. And I would like the comments from the surgeons for Dr. Malakassis, please. You want me to choose who's going to speak first? Please, Marulio.
I can ask. Thank you, girls, first. Thank you, Julia. I would like to congratulate Professor Moschetta for this excellent presentation. We do the same. We use this procedure in our center breast unit, Metropolitan Hospital, and we use it most of the cases for microcalcifications. We have at least 80% of women sparing the surgery. The microcalcifications are benign, so we can understand how important this device is and this biopsy, this kind of biopsy. I would like to ask you, what about the migration of the clip? Do you have many of them? Or what do you do when you see it immediately when you put it and you see that it's not in the right place? And the second question is, do you put the hook wires when it's needed for the excision, the re-excision at the theater? Do you put them by using the VAB or only the mammogram?
Okay, thank you for your comments and for your question. About the first one, today we have new markers. So fortunately, the migration is less common as in the past, based on the steric conformation of the marker. But we suggest in any case to have a very slow decompression at the end of the procedure, because probably if I'm going to have a fast decompression, then the clip have a higher probability of migration. So today is less common, but if I notice that at the moment, at the end of procedure, that we have a migration of the clip, it is highly suggest to have a reposition, a new marker inside the target. Then if for example, I have a B5, of course, you need to operate at maximum 30 days from the procedures, okay? Yes. And so you still have, because we have 9 gauge needles, so we still have granuloma in the site of the procedures, also if the marker is migrated. So thanks to the presence of granuloma, we can easily identify the target in still 1 month before the surgical procedure. We use hook wire because we are used with our surgeon. It is very simple, and for us it is very simple. And we have this positioning by ultrasound, because this kind of markers can be identified on ultrasound for 6 months. For 6 months. So we still have, if the marker is not migrated, we still identify the site of procedures for 6 months, because the marker can be is visible at ultrasound examination. If some colleagues or also me are not able to identify, I can use the table again in order to have a stereotactic marker of the lesion preoperatively.
Okay. And one more question. Do you know if they remove the migrated clip area also?
No, we don't remove. If we have the migration, we don't remove the migrated clip, but we remove only the lesion site.
The right one. Okay.
Yes. I know that is debated because probably some cells could be inside repositioning, but of course they will have, for example, if it is infiltrate, invasive cancer, or it will depend, and conservative surgery, there will be also radiotherapy after the surgery.
Okay, thank you very much.
Okay, thank you.
Dr. Venizelos, would you like a word?
Vasily.
Meanwhile, Petros can have the word.
Yes, you can. Okay. What can I say? I do that procedure in prone table in Euroclinic a lot of years, but biopsy with DBT, it's reducing time, the accuracy is better. I'm jealous. I hope that I have the opportunity to use a prone table with DBT soon.
Okay.
I hope you have the money too.
Yeah.
No, but for us it's very also the table, but also the possibility of having a direct imaging, because also for the workflow is simple. We don't move to another mammographic unit, for example, so you can still perform mammography on your normal unit, and this kind of unit is completely autonomous from the other part of the breast radiology center.
Thank you very much.
Vasilis, you are back on the move. Do you have something to say?
Me?
Oni.
No, I mean, I really enjoyed it. It was an excellent talk, Professor Mosqueta. Excellent.
Thank you.
I'm not going to discuss the technicality because we have very expert radiologists here, Ms. Christodoulidou and Dr. Malakasis. But I really enjoyed it, and I think I have to press harder my administration in the hospital to buy this new position table.
Technology.
I was really impressed by the new device. Thank you very much for your talk anyway.
Thank you. Thank you very much for your invitation. Thank you.
Thank you all for your patience and for being here in front of your monitors at this time. I would like to give the word to Dr. Dimitropoulos. I guess we are all thankful to him for organizing this whole webinar with all those prestigious speakers. So please, Nikos.
So after the whole day, after a whole tiring day, I think that we come to the end of this course. I would like to thank everybody, all the participants. I hope that today's course will help you to reorganize and improve your everyday job. Online, low-cost focused education by home comfort may easily contribute in upgrading our clinical practice in difficult time periods as now. I would like to thank the international presenters, Professor Tabar, Professor Maceroni, Professor Mosqueta, Professor Alcantara, Dr. Grevenhold, Dr. Zouzos, Dr. Papalouka, as well as the Greek team presenters, Dr. Mukhtouri, Dr. Vretou, Dr. Katsaros, Dr. Varaki, the breast radiologists, the surgeons, breast surgeons, the gynecologists and breast surgeons, and all the presidents and commentators of today's courses. I thank all the sponsors and the Secretariat. Without their support, it would be impossible to perform this online course. I wish you a happy and relaxed coming summer, and I hope to meet you again in our next webinar course. Thank you.
Thank you very much, Dr. Dimitropoulos.
Thank you.
Thank you.